Clinton from the Heart of Medicine, and this video specifically will be about another ABIM clinical pearl video. So I took a quiz earlier today, and yes, I am wearing this ugly looking scrub, but it's a hospital scrub, so don't criticize me too strong. This video is for those people who benefit from listening a little bit from internal medicine pearls while you are busy washing the dishes, taking the dog out, etc., etc. Okay, so I'm just gonna walk you through the things I learned from this question set. So let's go to the pearls, okay? So this first question is a 62-year-old male, which basically was having some chest pain, some upper abdominal discomfort for the past 6 months. And I'll just go to the point. The point is he was having has a couple cardiovascular risk factors, has hypertension, has type 2 diabetes, is on several medications, which are non-contributory to this question specifically, and underwent a exercise radionuclide stress test. After 5 minutes on the Bruce protocol, that's the usual one, right? The Bruce protocol, he is able to reach 85% of maximum age predicted heart rate. So what's the goal? 85%. Okay, so he reached it. His blood pressure at baseline was 148/88 and is 142/86 at peak exercise. He complains of discomfort in both arms and the chest during the end of exercise, which resolves 5 minutes later during the recovery period. So he was having some symptoms, right? Maybe not the most typical symptoms because it was both arms and all, but it was during exertion, so that's typical, even though it was both arms. And EKG was showing 2 millimeter horizontal ST depression in leads 2, ABF, and V4 through V6 at peak stress with normalization and recovery. Okay, so you already got that information, but look at this. However, myocardial perfusion images show no evidence of ischemia, and the ejection fraction is calculated at 65%. Okay, so what's the question? It is, which of the following is the most appropriate next step in management? So I'll read you the toughest options to decide from. One of them is going to be add clopidogrel and nitroglycerin as needed. Another one is evaluate for non-cardiac cause of chest pain. Another one is reassure and follow up in 3 to 6 months. And the last one is refer for cardiac catheterization. Okay, so this question almost immediately I marked as referred for cardiac catheterization, and that is the answer. So I wasn't exactly certain what was going on because, to be honest, I didn't weigh in too much after I saw that this patient had pain with exertion and that there was a depression of the ST waves with horizontalization, which there's 3 patterns. There can be upsloping, that's the most benign. Then there is horizontalization, that's the second one. And the worst is downsloping, right? But the patient did have the ST depression in leads that were looking at the same thing. So lead 2 and ABF are looking inferior wall. Lead 4 and 6 are looking to that lateral, anterior lateral wall. So we already have that, and that was enough. That's enough for you to send the patient to the cardiac catheterization lab. And the only thing that someone would hesitate is, but wait a second, the myocardial perfusion images did not show evidence of ischemia, so everything is fine. Well, that was the decoy, and that was just to mix your brain up a little bit into thinking everything was fine, when actually what was happening is that this patient probably had multi-vessel disease, and there's something called balanced ischemia, which basically is that the heart is doing so bad in all these different vessels that when they see the pictures or the images, it looks like if it's symmetrical, but it's symmetrically decreased. But maybe the human eyes, when you're analyzing this, you're like, oh no, it looks normal. Well, no, it's actually symmetrically decreased all over. So that would be balanced ischemia. And that's the main pearl from here. And of course, the patient needed the angiography. There are some EKG stress testing findings associated with poor prognosis or outcomes, such as not being able to get to 5 metabolic equivalents or METs. Also, exercise-induced angina during minimal expenditure, inability to achieve 85% of age-predicted maximum heart rate, fall in systolic blood pressure below baseline during exercise, ST elevation, more or equal to 2 millimeter ST depression during minimal expenditure, early onset of prolonged duration of ST depression during exercise stress test, ST depression in multiple leads, and ventricular couplets or tachycardia during minimal expenditure or recovery. So we have another friendly fly right here with us, and let's just continue without getting distracted. Okay, so the next question is basically asking us, do you know what sort of pain can occur here? Do you know which pain occurs right over here, over the styloid process of the radius, and worsens if you passively flex the first finger, right? So if you know the answer to that, you get the answer, basically, because that's what they were asking. They did show me an x-ray, but the x-ray didn't show anything special, and we're going to see the x-ray right over here. There you have it. That's the x-ray. The x-ray looks good, normal. And the question is, which of the following is the most likely diagnosis in this patient? So, let me show you the different options. Well, the main options I was between, like, would this be carpal tunnel syndrome or Deck-Vein tendinopathy? So I just ruled out everything because no, this wasn't carpal tunnel to me. It was close by, and I didn't exactly recall how Deck-Vein tendinopathy looked like, but now we're going to remember it better. So let's see it right over here. Let's put this right over here. No, it's not working. Wait 1 second. Here, and let's go here. Deck-Vein tendinopathy. So you have the extensor retinaculum here. You have the thickened tendon sheaths here, right over here. Abductor pollicis longus, extensor pollicis brevis, and basically the pain is right here, and that's why if you flex this first finger, it's going to hurt so much. And the main thing to learn here is that it presents with chronic lateral wrist pain that can radiate to the base of the thumb. Examination shows tenderness at the radial, styloid, and reproduction of pain by stretching the affected tendons with the wrist in ulnar deviation. So with the wrist in ulnar deviation, this way to the ulna, right, that way, and pulling on this. Okay, so there's the Finkelstein and Akoff tests. The diagnosis is based on clinical findings. Treatment includes activity modification, Spica thumb splints, and nonsteroidal anti-inflammatory drugs. Now let's move on to the next question. This next question is, okay, this is a patient, 64-year-old male that has anemia. The patient has a low MCV. The patient is suspected to then have probably iron deficient anemia, and had a brown stool that tested positive for occult blood. So patient got a colonoscopy and an upper endoscopy, didn't find much. So the question they're asking you is, what is the most appropriate next step in management of this patient? So the options are Meckel's scan, B, radial labeled red blood cell scan, C, serum tissue transglutaminase antibodies, D, small bowel electrolyte enteroclysis, and E, wireless capsule endoscopy. Okay, so the answer here is, yeah, you don't find the bleed. You're going to go with this little pill that's going to take images every so often, and you're going to find out if there's a bleed. That's the answer. I think the radial labeled red blood cell scan was the second one I had in line as a possibility, but I remember that is only when you have like a bleed or a faster bleed. You need at least, I think, 1 to 2 mLs per hour, or, well, we'll see the answer, but it has to be like a quicker bleed that you just want to find it, and that's a good way to do it. Let's see. Okay, what's the educational objective? Patients with both iron deficiency anemia and positive stool occult test are evaluated with a combination of upper endoscopy and colonoscopy to avoid missing simultaneous lesions. If both tests are negative, the next step for occult bleeding is small bowel evaluation with wireless capsule endoscopy. We already talked about that. So now let's see. Okay, radionuclide scans can detect overt GI bleeding, but the bleeding must be fairly rapid. Let's see. So the numbers were 0.1 to 0.5 ml per minute. Okay, so in 60 minutes, you're going to get 6 mLs. Right? About 6 mLs to 30 mLs. 6 to 30 mLs in an hour. So per minute, 0.1 to 0.5 mLs per minute. It is not a good option for patients with slow occult blood loss. Now let's go on to the other question. This other question, the main point here is a patient that had a cancer. So this patient had a 2.5 centimeter spiculated right upper lung mass with ipsilateral bronchial lymphadenopathy, but no other evidence of metastatic disease other than also having a 2 by 3 centimeter lesion at the gray-white matter junction with vasogenic edema, confirmed on MRI. So they're asking you, which of the following is the most appropriate next step in management of this patient's brain lesion? So I got this one incorrect. The options are A, brain surgery, B, combination chemo, C, hospice, D, sunitinib, E, whole brain radiation. Okay, so I was thinking like, this patient has metastasis. Probably doesn't make sense to operate, but actually the answer was to operate, and let's see why. Patients with solitary brain metastasis benefit from surgery or stereotactic radiation followed by whole brain radiation. Okay, so that was the answer basically. Imaging features suggestive of metastatic brain tumors. What are they? One is location at gray-white matter junction. Another is multiple lesions or large vasogenic edema or circumscribed margins. Okay. Nearly 40% of patients with systemic cancer develop brain metastases. That's very high, usually through hematogenous spread. Imaging features suggesting metastatic disease include circumscribed margins, location at the great-white matter, well, basically what we already said. This patient likely has primary lung cancer, which may be small cell or non-small cell. Brain metastases from small cell lung cancer appear to respond initially to chemotherapy, but studies have shown variable overall response rates without significant survival benefit. Adding a whole brain radiation improves the response rate to chemotherapy, but without significant survival benefit. Non-small cell lung cancer is not as chemosensitive as small cell, and brain metastases respond better to whole brain radiation and or surgical resection. As a result, surgical resection is usually considered for brain metastasis due to small cell or non-small cell. Okay, so this is mainly because the patient had a solitary, brain metastasis. If the patient would have had several, then the picture changes, and yeah, you would have had to do other things, probably chemotherapy and then whole brain radiation. So you just saw what we spoke about, depending if it's small cell or non-small cell. Okay. Let's see. Now let's go on to the next question. This next question is telling us about a 35-year-old man, and this patient is basically, they're trying to throw you off because the patient had a tuberculin skin testing done, which had 2 millimeters in duration with 22 millimeters erythema 48 hours after placement. The patient was not HIV positive and normal complete blood count and metabolic panel. Which of the following is the most appropriate next step in management? So one is A, 4 months of rifampin, B, chest x-ray, C, no further testing or treatment, D, quantiferin TB gold assay test. I got this one correct because you always are told that the TB or the PPD, the way you evaluate it is with induration, not erythema. So the induration was only 2 millimeters. That's not positive in any risk group. Even patients that have high risk, the least in duration you will need is 5 millimeters, okay? Intermediate risk, you'll need about 10 millimeters. And all the healthy people out there, you're gonna need in duration of 15 millimeters. Remember, not the erythema, it's the in duration. So, which is the high risk population? Meaning more than or equal to 5 millimeters in duration would be positive. Individuals with HIV, recent contacts of patients with known TB, persons with nodular or fibrotic changes on chest x-ray consistent with previously healed TB, and organ transplant recipients or other immunosuppressed persons. So all those, that would be 5 millimeter cutoff. So just learn that one, and healthy individuals will be 15, and everything that you're like on the fence, like, yes, this sounds like a little bit risky, but not that risky, it's gonna be 10 millimeters, okay? Just so you have the point clear, I'll tell you what's gonna be 10 millimeters. Recent immigrants being less than 5 years from TB endemic areas, that's gonna be 10. Injection drug users is another one. Residents and employees in high risk settings, okay? Prisons, nursing homes, hospitals, homeless shelters. Mycobacteriology, laboratory personnel. Persons with conditions that result in higher risk for TB reactivation, such as diabetics, leukemics, end-stage renal disease, and chronic malabsorption syndromes. And children age 5 or less, or those exposed to adults in high-risk categories. Okay, we nailed this point. Let's go on to the next one. Next point here is basically patient, 54-year-old woman. Everything is going well. She is a cigarette smoker, was found to have a DVT in her lower extremity, confirmed by Doppler ultrasonography, and vital signs are normal. Everything is quite normal. She is just having some pain in that swelling in the left leg where the DVT is and nothing else. So the question is, which of the following is the best next step in managing this patient? They're giving you different options. Some of them, two options are admitting to the hospital. So admit to the hospital for enoxaparin. Another is admit to the hospital for unfractionated heparin. And another is outpatient therapy with dabigatran and repeat ultrasound in 2 weeks. The other outpatient one is outpatient rivaroxaban and clinical follow-up. And the last option is supportive care only and clinical follow-up. So yeah, I got this one correct because you know that if when you have a DVT, you have to treat it. So supportive care is out of the way. If the patient has no risk factors and is doing fine, why will you admit this patient? There's no reason to. So options requiring hospital admission are out. So we're left with two options, which are outpatient, DOACs, direct oral anticoagulants. But one is asking us to repeat ultrasound in 2 weeks. The other one is just asking for clinical follow-up. So usually the answer is going to be clinical follow-up. So it was rivaroxaban and clinical follow-up. And the educational objective is, let's see, why wasn't it to repeat the ultrasound? Repeat ultrasound at 2 weeks is not indicated unless there is clinical concern for clot extension. That's it. We got it. Let's go on to the next one. This other question is telling us about a patient with hyperkalemia. The patient has chronic lymphocytic leukemia and hyperlipidemia. The patient was not taking her medications as prescribed, so that chronic lymphocytic leukemia is doing pretty bad, and the patient is now coming in with point tenderness at the L2 level. They give us some labs showing that the patient has a platelet thrombocytopenia of 85,000, hematocrit is 27%, meaning so anemia, thrombocytopenia, and hyperleukocytosis, so a leukocyte count of 180,000 with lymphocytic predominance, and they're showing you a potassium level of 8.2, with the uric acid of 6.2, etc. Okay. Oh, they show us an electrocardiogram which is normal. So I had not seen that specific information. I was actually, when I saw the potassium being 8.2, I was thinking to myself, oh, this patient probably has peak T waves. And I didn't ever see any information about the electrocardiogram. The interesting thing is that, yeah, I just didn't see it. So that would have helped me probably answer this question a little better, but I would have got it incorrect because the option says the next best step in the management of his hyperkalemia. So I'll tell you the toughest to choose from. One is insulin and glucose. Another option is intravenous calcium gluconate, and the last one is analyze whole blood potassium by using arterial blood draw. Okay, so yeah, the actual answer here, I wouldn't have gotten this one correct because I was thinking about reducing the potassium immediately. This for me was an emergency, and even more without any EKG information. So I chose insulin and glucose. It was not correct. And since the EKG was normal, probably something's off. You won't have a potassium so high with normal EKG. So the real answer was analyze whole blood potassium by using arterial blood draw. Okay, so what happened here? This was pseudo-hyperkalemia. The presence of significant leukocytosis or thrombocytosis is associated with spurious hyperkalemia. And the patient should have a redraw of arterial blood with care to prevent hemolysis. No tourniquet or shaken, stored on ice, and promptly analyzed. So why an arterial blood draw? I'm not sure why. Let's see if we have an answer for that. But yeah, almost all patients with a potassium above 8 will have some EKG changes. Let me see. I'm trying to take the dogs to the park, so I have no answer here. Okay, perfect. So hyperkalemia says, let's see what it says specifically about the how to analyze it. So very high white blood cells over 50,000 and platelet counts over 600,000 are also associated with significant pseudo-hyperkalemia due to the mechanical stress of the blood draw releasing potassium from deceased or fragile white blood cells and platelets. In this situation, it is recommended to obtain arterial blood. Oh, okay, that's because you don't need a tourniquet. So if you don't need a tourniquet, you're not increasing the risk of friction, I guess, and injuring those blood cells, resulting in the hyperkalemia. Because a blood draw, arterial blood draw, you know that you just press here, boom, and the pressure is so high that it's going to fill out on itself. You don't even have to draw back, right? Okay. Next question. What's the pearl on this one? Let's go faster. This patient is a 24-year-old male. He started acting a little bit weird with psychosis and personality changes about 4 weeks ago. It was prescribed low-dose risperidone initially. Then he developed a tremor and gait abnormalities. His father died from liver failure at age 40. And yeah, I think that's enough for you to think what this diagnosis is. So this sounds like this is bilateral. Well, there's also bilateral resting tremor noted in the hands. So all this sounds like it's Wilson's disease. And the question they're asking is, which of the following is the most appropriate next step in management? So I have gotten this question incorrect years ago. And why was it? Because I would see an option that said, eye slit lamp examination. And immediately I'd be like, no, cross this out. What's this? Why would you do this? Well, that's what you do to look for the Kaiser-Fleischer rings, which are highly specific, not so sensitive, but highly specific for Wilson's disease. So that was the answer, basically. Chronic liver disease associated with neuropsychiatric manifestations suggests Wilson disease, which is caused by a deficit in copper transport. Okay, so usually the copper is going to be pretty elevated. Kaiser-Fleischer rings are characteristic, but their absence on slit lamp examination does not rule out the diagnosis. Okay, so how do you diagnose it usually? Let's see if it explains here, because I remember that it wasn't only the copper wasn't that useful. It was more the ceruloplasmin. But it says here, diagnosis is supported by increased serum and urine copper levels. Okay, and decreased serum ceruloplasmin levels. Okay, so increased serum and urinary copper, decreased ceruloplasmin. That's it. Let's go on to the next one. Next one here is, okay, patient that is 70 years of age, having general weakness and headaches, has intermittent episodes of blurry vision and 6.8 kilogram weight loss in the past 3 months. So based on this, you should already be thinking on something for the test, right? Maybe I'll throw in, well, it's not in the test, but no, I'll just give you the information on the question. We have the labs, and the patient has an erythrocyte sedimentation rate of 120. That should ring a bell. And ferritin is 390. That doesn't ring a bell that much, but I already know with this information they're saying temporal arteritis. And the question they want to get to is, what's the next step in management? So one of the options is glucocorticoids. That's the answer. You want to do that quick. So criteria effective for distinguishing giant cell arteritis from other vasculitis include age over 50, localized onset, new onset headache, erythrocyte sedimentation rate over 50, and temporal artery tenderness. Diagnosis is confirmed with temporal artery biopsy, but treatment with glucocorticoids should be initiated immediately. Okay, so that's about it. For that, let's see, increased ferritin. Let's see what's up with the ferritin. Increased ferritin levels can suggest hemochromatosis, but ferritin is also an acute phase reactant that can be elevated in inflammatory disorders such as giant cell arteritis. This patient's normal transaminases make hemochromatosis less likely. Okay, next question. 4 to go, okay? So this question is asking us, okay, this is a 41-year-old female who was found to have irregular menstrual periods and intermittent milky discharge from both breasts. Additional to that, we have an MRI showing a 7 millimeter pituitary mass. The patient is very reluctant to start any treatment. The patient's vitals are normal. Prolactin is 90, so it's elevated. TSH is normal. T4 is normal. The question is, which of the following is the patient at an increased risk of developing if her current condition is left untreated? So basically, the prolactinoma. Is this a macro or is it a micro? It's micro. Less than 10 millimeters is a micro prolactinoma, right? Not macro, it's micro. Okay, so I got this one incorrect. These are the options. A, endometrial cancer. B, osteoporosis. C, panhypopituitarism. D, tricuspid regurgitation. And E, vision loss. So I was between panhypopituitarism and vision loss, because you know that if it grows too much, it compresses the optic chiasm and you lose sight. And if it maybe grows, it also can generate panhypopituitarism. But actually, the answer was neither. The answer was osteoporosis. And why was that? It's because hyperprolactinemia suppresses gonadotropin secretion and leads to hypogonadism, which leads to low estrogen levels with bone loss and osteoporosis in women. Microprolactinomas are generally slow-growing with low risk of rapid enlargement. Okay, so that's the reason. Now let's focus on why the others weren't. It says most microprolactinomas do not grow substantially over time and do not usually cause compression of surrounding tissues. Compressive effects, for example, panhypopituitarism or visual field defects, are more likely with macroprolactinomas, which are a more common presentation of hyperprolactinemia in men and postmenopausal women. Now question number 11. Okay, this is one that's always a little bit tough because it's basically telling us that there's a 35-year-old woman that has all the findings for Cushing's syndrome. So the patient has gained weight in the past year, significant weight. The patient has fatigue, difficulty lifting heavy objects. The patient is on an oral contraceptive with combined estrogen progesterone and hypertensive, has facial plethora, etc. So yes, the patient has Cushing's syndrome. But the question is, which of the following tests is the best next step in establishing this patient's diagnosis? Option A is ACTH level. Option B is cortisol level at 8 a.m. Option C is late night salivary cortisol. Option D is MRI of the pituitary gland. And option E is overnight 1 milligram dexamethasone suppression test. So this question, most people got it incorrect, actually. Only 22% got it correct. So I would have I would have gotten it correct, but I probably wouldn't have understood exactly why I got it correct. I was down to two options. I was down to cortisol level at 8 a.m. between that one and late night salivary cortisol. But actually, those weren't the two. Well, late night salivary cortisol was one of the strongest options, and overnight 1 milligram dexamethasone suppression test was the other. And the summary for this is what? So Usually, the best answer will be here, which is the most sensitive. We're gonna read it. Diagnosis of endogenous Cushing syndrome requires confirmation on at least 2 different screening tests. Options include low-dose overnight dexamethasone suppression test, late-night salivary cortisol, and 24-hour urine-free cortisol. Estrogen, here's the key point. Estrogen in the oral contraceptive increases cortisol binding globulin and total cortisol, resulting in a false positive on a dexamethasone suppression test. So that's what happened. Since the patient was on contraceptives, you couldn't choose the dexamethasone suppression test. The answer was the late night salivary cortisol. Okay, and morning cortisol levels without dexamethasone suppression have a low sensitivity and specificity for Cushing syndrome and are not recommended as a screening test. And I see it ordered all the time, right? Okay, so I got a little bit sleepy here, and let's try to wrap this up. We have, let's see, 3 questions to go. This other question is a patient that has mottling of subretinal pigments and bright yellow drusen deposits in the macular area of the left retina. So this patient has been having some vision deterioration with these findings on the fundoscopy. And the question is, what is the best initial management for this patient's vision problems? So patient's blood pressure is 155/77. BMI is 31, and the rest of it is largely unremarkable. The patient is a smoker. Yes, the patient also smokes daily for 38 years. Options are A, aggressive hypertension control, B, daily low-dose aspirin, C is immediate smoking cessation, D is laser photocoagulation, and E is weight loss. I got it incorrect. I said aggressive hypertension control, and that was not the answer. The answer here is immediate smoking cessation. And why? Because dry macular degeneration typically presents in older adults with progressive vision loss in one or both eyes and subretinal drusen deposits with pigment abnormalities on fundoscopy. Smoking cessation and daily antioxidant vitamins with zinc can reduce the risk of disease progression. So that was the answer. Treating hypertension and the losing weight is a little bit controversial in this specific context regarding reversibility. And yeah, that's about it. Laser photocoagulation can be considered in patients with wet AMD, not this one, which is dry. So how can you differentiate dry and wet? Okay, the difference is, I think, in the fundoscopy. Okay, fundoscopy, let's see, dry AMD can progress to wet AMD, which presents with acute vision loss, and metamorphosia, which means distortion of straight lines due to subretinal hemorrhage and or fluid accumulation. Let's go on to the next one. We're about to finish. And this next one is basically telling us about a patient that is 54 years of age, was hospitalized because of shortness of breath, orthopnea as well, has heart failure with ejection fraction 30%, bipedal edemas, and also has a history of HIV. Last CD4 count was 450. Antiretroviral therapy has been continued since admission. Patient right now, what he has is severe right foot and ankle pain on the 4th day of a hospitalization. The patient was initially treated for high heart failure with reduced ejection fraction with diuretics, and examination reveals redness, warmth, tenderness, and decreased range of motion in the right ankle and midfoot. There is no skin rash. Leukocyte count is 13,200, normal creatinine, and there is some significant soft tissue swelling, and a heel spur is seen. So which of the following is the most likely contributing to this patient's foot pain? And option A, antiretroviral therapy. Option B, embolization of cholesterol crystals. Option C, loop diuretic use. Option D, presence of a heel spur. And option E, tibial nerve compression. So I immediately crossed out tibial nerve compression. Doesn't make any sense here. Presence of a heel spur. I'm like, no, it doesn't make sense. It shouldn't be febrile. Shouldn't have leukocytosis. Embolization of cholesterol crystals is something that will happen post catheterization, but that just doesn't fit the picture well. So I was between antiretroviral therapy and loop diuretic. The answer was loop diuretic. Yeah. So the patient actually had acute gout, and it is a common manifestation in hospitalized patients. Can be triggered by infection, surgery, trauma, dehydration, medications, and impaired renal function. Loop diuretics can cause acutely elevated serum uric acid and trigger a flare of gout. So that was the answer. And now let's go to the last one. Woo! You can see me. If I just lay in bed like this for 5 minutes, I'll get a great nap. I'll do it before I take the dogs out. Let's just see the last question. This is a 35-year-old male, has chronic low back pain and gastroesophageal reflux disease. Let's see what's going on. Okay, interestingly, they give us several important things on the clinical exam. They say that he has a murmur, third heart sound is present, pulses are 3+, so increased. Early decrescendo diastolic murmur, best heard at the left upper sternal border. So whenever you're reading these questions, don't get too stressed out on all these characteristics, because, for example, I was just focusing on each of these, and I was reading very slowly, and I was like, okay, what can this murmur be, and this and that, and I got to the conclusion, okay, this probably sounds like aortic regurgitation, but I just had to keep on reading. Like, if you just keep on skimming through, you will see that at the end it says, X-ray shows normal lung fields, a moderately enlarged cardiac silhouette, and widening of the mediastinum. The chest CT shows a dilated aortic root, 4.4 centimeters, without evidence of dissection. So you didn't have to stress out with the prior things. You just have to keep on skimming through and coin that this is aortic regurgitation due to a dilated root. And you didn't have to think, oh, it's the sound is here and this and that. That's going to waste time on an exam. So chronic back pain, or some articular pain plus this aortic root dilation with regurgitation in a sort of middle-aged man. Probably the question is, which of the following is the most likely diagnosis? So you have option A, ankylosing spondylitis, B, rheumatoid arthritis, C, syphilis, and D, systemic lupus, and E, systemic sclerosis. I got it correct because I was able to retrieve this information. So it says ankylosing spondylitis usually presents with chronic low back pain in patients aged less than 40, usually more in men. Extraarticular manifestations include anterior uveitis, aortic regurgitation due to aortitis or valve dysfunction, decreased chest expansion, and osteopenia. So that was it basically. Syphilis. Yes, syphilis can also generate aortic root dilation and regurgitation, aortic regurgitation, but spinal involvement would be very uncommon. And the enthesitis, which is the pain, enthesis is the joining of the tendon with the bone, right? That tendon area or inflammation of the, not the tendon, but the joining of those two, that's called enthesitis. And that's more of ankylosing spondylitis, okay? So that's it for this one. See you in the next one. Hope you liked it. Give me feedback. And now I'm gonna go take a nap, little nap.